Welcome to the LowCarbUSA podcast, where we seek to inspire you to help us build this community. I'm Doug Reynolds.
And this is Pam Devine. Okay, everybody, thank you so much for joining us. Today we have Dr. Alexandra Sowa with us. She's dual board certified in internal medicine and obesity and metabolic medicine out of New York. Joining us today, and it's so nice to have you, Alexandra, and introduce you to everybody and what you're doing, not only in your practice over the many years of doing it, but also launching a new company that's going to make it easier for practitioners to measure and have their patients measuring for metabolic health through easy put together package for lab work. And I'd love for you to tell us all about what you're doing with that and through your practice.
Well, thank you so much for having me. It's honestly a pleasure to be here. So yes, that was such a nice intro. So I've been practicing in the field of metabolic health and obesity medicine for years, and I have a practice that I call a holistic practice in New York City that combines targeted nutrition and medical management to really help people reverse and prevent disease, which is, I find there's nothing more fulfilling than that. And out of my years of experience meeting with patients, people would come to me with symptoms, and they'd complain of everything from brain fog to weight gain to decreased endurance, irregular periods. And they would bring me labs from their outside practitioner, in the more traditional healthcare setting. And they'd say, well, I really think something's wrong on the inside, but my doctor says I'm fine. And I'd look at the same set of labs with my specialty training, and while they might not have had full-blown disease yet, there were surely all the signs of early disease that explained their symptoms, everything from insulin resistance to metabolic syndrome to an underactive thyroid to vitamin deficiencies. And it just kept happening over and over again to a point that I said, okay, that's it. I'm going to start a company that will allow people to test their labs with a specialty perspective from the comfort of their own homes. And so over COVID, I launched a company called Sowell Health, and we are a direct-to-consumer metabolic health kit company. And we are specifically looking at the diseases of metabolic dysfunction. Our first kit was targeting the symptom and disease of weight gain and obesity, and really helping people to look deep for an underlying cause. We have a second kit coming out that's looking at PCOS. We have more in the heart health and metabolic fitness spaces. And the underlying factor of what we're testing for comes down to something that I'm so excited to talk to you about today, which is insulin and insulin resistance, and the thing that goes underdiagnosed in the traditional healthcare setting. So that's what we have built, and we are partnering with practitioners to really help use it in their practices and with their clients to help people understand their data, which is so often kept away from them behind layers of an EMR, and it's hard to get, can't access it, and you can't get what you want tested. So we are providing that service.
That is so fabulous. And we were really excited to hear about it and the education part. So you're not only providing the ability for somebody to test their insulin,
right,
and then you're also providing some feedback on the results to the patient and the physician, correct?
Right. Yes. So right now we're doing it just to the person who's ordering,
Yes.
But we're looking to expand that so that the provider too can kind of get a peek inside too, and whoever orders it. But yeah, it's not just lab tests, because what use is a lab test if you're not trained in how to understand it? And I know so many of your listeners are already empowered and know so much more than the general population. But if you just drop fasting insulin in front of someone, it's not going to mean much. So we have built out a proprietary tech portal that takes all the lab data and puts it together in a unique way. And we discuss things like a HOMA IR score, and we talk about what insulin resistance is and what to do about it, and why metabolic syndrome matters if we see that on your labs. And it's not just a number drop, it's an information exchange.
Yeah. And, you know, now that you mention it, you know, a lot of our followers may already be versed in it, but I always like to address the person who's just tuning in, who's stumbled across the video and actually doesn't know that stuff. We always want to continue to bring awareness. So if you would mind delving into that a little bit, you know, what does insulin, what is the role that insulin plays, and why would you want to look at it sooner than later? And what could that show somebody, what's going on internally? And let's start the conversation and raise awareness and see if we can't get more people to listen to this.
Fantastic. So let's take it back a step further from insulin. Let's just talk about metabolic dysfunction. So here's a shocking number. 88% of Americans specifically have evidence of metabolic dysfunction on their labs, and only 12% of American adults are fully metabolically healthy.
And we can provide the relevant study to that if anybody's looking for it. And you can even just Google that and it'll come up.
Yeah, we've got it all over our website too, because it's something that people need to know, right? And just because you yet haven't been diagnosed with this full-blown disease that the traditional healthcare system likes to treat and not prevent, doesn't mean we can't do something about it at the beginning. And we see that by looking at fasting blood sugar, looking at a series of cholesterol markers, not the cholesterol markers that everyone always thinks about, rather, not the quote unquote bad one, which we know is not bad, LDL, but rather a too low good HDL, right? And that's too low. Or we have elevated triglycerides, which represent free fat floating around, representing excess energy, usually in the form of carbohydrates. We also, waist circumference comes into play there. So it actually has nothing to do with the number on the scale, but where you're carrying your weight. And I think I said fasting blood sugar already, but yeah, it's one of those 5 metrics. And blood pressure, that's what it is. So it's a systolic and diastolic blood pressure. So if your lower blood pressure is too high, that goes into meeting metabolic dysfunction. So notice we didn't talk about insulin yet, and that's actually where I think we need to take a step further in education. So that we diagnose metabolic syndrome, 3 out of 5 of those criteria, and 88% of Americans have one abnormality in those 5 criteria, which is really quite remarkable. But what leads to those problems, and the root cause of the majority of those findings, is rooted in insulin resistance. And our bodies produce a hormone called insulin through our pancreas, and we need it to live. And most people think about insulin as a good thing and as a life-saving thing, and sometimes something that people need to inject to live. And that is true. But for the majority of people, what happens is that your body overcompensates and produces too much insulin. But your body isn't responding to that insulin. And that's where this term insulin resistance comes from. So insulin's job is you eat some carbohydrates, your blood sugar goes up, insulin is supposed to wrangle the blood sugar and deliver it out to your body for use. What happens over time to the majority of Americans with our traditional Western diet, not just Americans, all over the world, but the traditional Western diet that has now gone all over the world, is that over time, your body can't take and deal with that glucose load that keeps getting higher and higher. For a long period of time, for years and decades, your body will compensate and keep that blood sugar down at all costs. But the cost is the insulin going up and up and up and up, and your body becoming more and more resistant to those insulin signals. And that is the first insulin then, is the first marker we see that has derangement. It's well before your fasting blood sugar goes up into the quote unquote abnormal range above 100, or your hemoglobin A1C is creeping up into the pre-diabetes range. Insulin is the first marker. And that's where I think we're going so wrong in the traditional healthcare setting. We wait to see problems until they've manifested into the fasting blood sugar and to the elevated hemoglobin A1C, and we can see it on insulin. And there's been a lot of controversy, I'd say, around insulin, because for years we thought it really had to be tightly controlled and validated in a hospital setting with lots of protocols, and then didn't have utility. And that's just not true. It's been proven out in many mathematical models and scientific studies to have a lot, to have scientific validity, especially when you combine it with fasting glucose. And we put it together. We like to use the HOMA-IR score, and we use that in our testing kit to really help people understand where they fall in the spectrum of insulin resistance. So, that was kind of a scientific explanation, but it's the takeaway is that insulin derangement is the first thing that we see, and we should be looking for it. And we're not looking for it in traditional doctor's office, healthcare setting.
Yeah, it's really a shame. And I know Dr. Ben Bigman's book called Why We Get Sick, if anybody wants to look into that, he talks just about that at the beginning of his book. It's why did traditional medical care and standards of care right now, why have we only been looking at blood glucose? And blood glucose became the focus of diabetes is high blood glucose. But when you look at Dr. Kraft's work and the way that insulin is actually rising, sometimes, like you mentioned, over 10 to 20 years, it's something that you could look at 10 to 20 years before diabetes sets in. So if we can start testing for it earlier, we can stop that train of going to diabetes. Now, practitioners are looking at blood sugar and fasting blood glucose for diagnosing pre-diabetes and diabetes. But if they could start diagnosing hyperinsulinemia much sooner, we could stop that trajectory with bringing awareness and education about the amount of carbohydrates that are consumed in processed foods and sugars that are consumed over that amount of time period. Because people sometimes think they just wake up with diabetes and it's genetic, and when it's really a physical reaction to an overconsumption of carbohydrates over the years, those many years. And I think if more people understood it, if more practitioners understood it and get that aha moment of we could start looking at this sooner, and then we could prevent more than treat and put a Band-Aid on with medications. Because now I know there's a lot of conversation about pre-diabetes, so the education is you can stop this now, but there's a lot of misinformation out there that says, oh, you have diabetes and there's nothing you can do about it now that you have type 2 diabetes. You're just gonna, what's the term that everybody hears, chronic and progressive, when it's not chronic and progressive. If you're going to halt those reactions to the consumption of it, you could actually reverse it. And I know there's more and more documentation of if you want to use the word remission or reversal, whatever term that we can get people comfortable with, and people can look this up too. There's more and more studies showing the ability to reverse and put into remission type 2 diabetes and hyperinsulinemia, right?
So that's exactly right. And it's so important to understand that the reason we're looking for this is not just to get another lab value, but it's really for early diagnosis. I like to call it pre-diabetes. And I find it incredibly motivating for people, because if you can change your lifestyle habits earlier, you will set yourself up for years of not having a struggle of starting and stopping. But if you understand why you should be eating a certain way and you see improvement in the numbers that might not yet be reflected in those things that we were talking about, like fasting glucose or hemoglobin A1C, because it hasn't been affected yet, but you're starting to feel some of the symptoms of it, it's incredibly powerful. So if you see that you have evidence of insulin resistance and you've been noticing that weight has been creeping on, that you feel a little fatigued, that you might have PCOS and have irregular periods, then an elevated insulin level will give you motivation to understand exactly how you should be eating. It's almost like an amazing roadmap, and you don't have to second guess how you should be eating. And I know we're on the Low Carb podcast today, but the way you should be eating is embracing a lower carb way of eating and really understanding what your macronutrients are. And it's something that we blow past and are taught incorrectly in all of our years of growing up, that, we should be basing our food pyramid on grains and fruits and all of these carb-laden foods, but often they work very much against us when we start to have evidence of insulin resistance. And the disease itself and all the symptoms that come with it are accelerated. So I think it's incredibly powerful. I say that our kits, and specifically insulin, are helping people to unlock their metabolic health. And it really is so eye-opening and motivating. And it's just such a clear pathway for people when they can see, okay, this is what I need to do now. I need to understand what a carbohydrate is. I need to reduce or maybe even go full keto, depending on what way in my life will embrace this and what I need to change and what can be sustainable. And you can then check your insulin levels to see how you're responding. And the amazing thing is if you go low carb, that insulin level is coming down because insulin only exists there in excess in response to carbohydrates. So you reduce the carbohydrates, you reduce your insulin level, and it's a beautiful thing.
Yeah, I'm so excited just of this concept of having an insulin test because, right now, if I want an insulin test, I have to go to a doctor. First of all, I have to find a doctor who's prepared to refer me for an insulin, like to order an insulin test for me, because most of them refuse.
Right.
And then I have to go to the lab and get it done. And now I can literally get a kit sent to me, do it, send it in. Next brilliant step, hopefully Dorian Greeno at Keto Mojo will come up where we can eventually actually test it at home.
Yes.
But right now, even just being able to order a kit and send it off without having to find a doctor or go to the lab or anything is amazing. I mean,
isn't that such a pain point? I mean, to find a doctor or a practitioner who can order labs and will order insulin is no small feat. I think in my years of practicing in New York City, which is densely populated, and we have, different thinkers, I think I've had one patient come into me with labs that had tested a fasting insulin, and this is the population who we should be testing 100% of the time, and it's just not done. And people think it's quacky, but it's not. It's based in evidence and science, and it is a bit of a shame that more people who are treating the disease aren't looking for the preventative solutions.
Yeah, and getting to the root cause of what is the actual biochemistry and how does it start and how does it change and how does it become dysfunctional. And I know we are on the LowCarbUSA podcast currently, but the work that we're doing with the Society of Metabolic Health Practitioners is addressing just that and trying to figure out campaigns to bring more awareness, campaigns to bring more education, starting in medical schools, where we can get into curriculum and into the continuing education, medical education and conferences, into more research and published in journals so that this can be understood more, that getting to the root cause of looking to see what insulin is doing so many years before can do. I would love to hear your ideas on, some of those hurdles and bringing education to doctors, but it seems like there's either a dissonance or just a lack of education currently with
it takes 17 years for what we know to be true to be adopted in clinical medicine. Mm-hmm. And I think we're getting there because I would say in my training, I remember you were talking about a diagnosis of prediabetes and people give a spiel about, you can reverse it now. I think the way I was taught was, yes, you could reverse it now, but we're really not going to offer you anything until you get to the diabetes. Like, you can maybe go talk to a nurse educator maybe, but I don't even think we had the resources until people were all the way to type 2 diabetes. And it was diagnosed as this inevitable thing, maybe eat less, exercise more. That's all I learned in my education. And I just knew it was so flawed because you would look around at the chronic diseases that we were managing, end of life chronic disease, and you'd be like, the root cause of all of this is obesity. And what I've now learned is metabolic dysfunction, right? Obesity is really a symptom of the metabolic dysfunction. And I sought it out, and I was so lucky to have found networks and independent physicians who were really just taking other doctors under their wing. And you really need to figure out a way to scale it. And so it's so great that organizations like yours are starting to do some of the education. And I would love to get more into the early years of medical school, nursing education, and introduce these topics earlier and kind of make them part of core curriculums. There's a movement to make nutrition part of core curriculums, but I'm sure, as you guys know, a lot of nutrition that's taught is very outdated. And it's not encompassing of the fact that by the time we have a problem, metabolic dysfunction is already there. So we've got to take a different route, a different approach, right? When you're lean and young and healthy, we might be able to embrace more of a whole foods, fruit, vegetable, grains approach. But once that you tip over and you start to have elevated insulin and you've put on a few pounds a year and your fat pathways take over, we really need to take a different approach. And I think it really starts with education, and I think it's a lot of lobbying. I think that I think we need more advocates within the academic setting, which is tough. I think a lot of free thinkers do leave academic settings, but we need to try to get more into the base curriculum. My society, the American Board of Obesity Medicine, is really starting to grow and make inroads. And we're really starting, as part of our advocacy, is trying to get back to the underlying education. But it's tough, and there's a bit of a battle. But I think the more that consumers, patients are educated, they are empowered to different pathways for education, podcasts like this, and courses and books. And the more that they can learn and even bring it into their doctor and create doubt, well, that's how, some doctors will start to learn about this too, right? And then they'll start to look it up and learn too.
I think that's the way a lot of doctors that are on board with us, how they came about it. It's like two pathways. One, they either are sick themselves and on the quiet often try it out for themselves and notice this monumental change or the reversal of the condition or whatever. And then they hear that there's so much information out there and these conferences like we put on and that, and then it's like, okay, now I'm going to actually talk to my patients about it. The other way,
it's magic. You see it in one or two patients, and then there's no going back.
Yeah, well, that
you might be scared at first. There's no going back. Yeah,
and Dr. David Unwin in the UK is one of those examples where one of his patients actually opened his eyes for him. And she wasn't filling her meds, and he called her in, and she came in, and he didn't even recognize her in the waiting room. He literally told her that she must be early because he's waiting for someone else, because he didn't recognize her. She had lost so much weight, and she looked so much better. But she'd gone out and found it out for herself, and she was just doing it on her own. And something that I didn't know until I did a podcast interview with him fairly recently. And but the bit of the story that I didn't know was that he told me that she actually yelled at him. Like she was angry with him for not telling her about this.
Yeah.
And I started to make excuses. Oh yeah, well, for him, like, so you guys don't get taught that at university and stuff. And he said to me, Doug, he said, that's no excuse. He said, I should have found out. I should have known. That information was out there. And that's what happens to so many doctors, is it just bounces off because it goes against, like 180 degrees against what they were taught. And so they literally just refused to see it. And he said, if I had paid attention, if I had done my due diligence, I would have learned about this and I would have been able to help her. And now he's totally committed to doing that. But he's like Tim Noakes, just that's the sign of a great man, that he can actually acknowledge his error and apologize for it and actually commit to putting it right. So
I love that. And that's, I think anyone who's listening who's thinking about changing their practice, it's okay if you thought one way, and it's okay if you'll continue to evolve. If always you're curious and that are, as practitioners, we still do no harm and do all the good, right? I think sometimes we need to change that. So just because we're not harming someone, are we helping? And if you kind of keep up that idea of how can we best help, as the science evolves and as our resources evolve and our community evolves, we'll be able to offer more and more and more. And I've even been able to change my practice from when I exited residency, and the confidence you get in embracing low carb and ketogenic and different nutritional therapies, and really looking at nutrition as therapy, and not just an adjunct and a curative therapy.
Mm-hmm.
You can continue to evolve. And I think that's actually wonderfully exciting.
It really is. And we've talked to practitioners time and time again where it actually brought hope to their practice, and to them getting up in the morning and realizing that they're now making a difference when they didn't feel like they were before and felt really frustrated. I know, Doug was just talking about Dr. Unwin, but it's reverberated and echoed many, many times over when he was saying he wanted to retire. He didn't feel like he was making a difference. And it's very frustrating to many practitioners, and hopefully some are listening who haven't actually embraced what we like to call therapeutic carbohydrate reduction, because when they were first trained, like Dr. Unwin had been getting older and been in practice for many years, and that type 2 diabetes was only seen, like you had mentioned, in the elderly population, in your aging population. It wasn't seen in teenagers and 20-year-olds and kids like it is nowadays. And the statistics are just out of this world and mind-boggling. So if we can encourage anybody to look on the Society of Metabolic Health Practitioners website, and it can be accessed through LowCarbUSA as well, the clinical guidelines that were laid out with a lot of the people that Doug just mentioned, who were a part of putting it all together with Adele Height. And patients can bring this to their physician if they're not quite understanding what carbohydrate reduction can do, the history of it, what needs to be looked at and monitored, like you're talking about with your lab work, what can be addressed. Like you were just talking about at the beginning, I think a lot of practitioners don't understand that hyperinsulinemia could be at the root cause of high blood pressure and hypertension. Maybe you could go into that a little bit, because I know that's something that Dr. Unwin's tried to make sure he's raising awareness about, because everybody always talks about lowering salt intake. And
drink your pickle juice.
That's like the one thing that everybody always says, lower your sodium intake. But let's look at what is actually causing hypertension.
So what is hyperinsulinemia? It is increased inflammation, really. And that's when your glucose starts to become elevated in any capacity. It's overall inflammation. And that's where the damage is done to our vessels. And we have a compensatory mechanism where your vessels and your kidneys you will start to create a hypertensive state. And it goes very much hand in hand. And we've known this, and we know it to be true. And this is why when we diagnose metabolic syndrome, that diastolic blood pressure is one of the criteria, right? We're looking at blood sugars, we're looking at waist circumference, we're looking at blood sugars, and we're looking at that blood pressure, and they're all interconnected and related. And so, yes, I have found even in lean people with elevated blood pressures, you will do the deep dive on their metabolic health, and you'll find this early insulin resistance. And everyone is generally concerned, you have a lean individual who's already healthy, and now you're going to put them on a lot of fat in their diet, and it's going to throw everything off whack. And that's just not the truth. And what you'll find is that even with just subtle reductions in carbohydrates and insulin, you will bring down their blood pressure. It's all very much interconnected, and it's something that one of the big problems, I think, in healthcare is that we segment all of these specialties, right? So you're going to a cardiologist for the blood pressure and for potentially the cholesterol, and then maybe an endocrinologist for your blood sugars, maybe primary care is ordering it and overseeing it, and they should be more involved, but the healthcare system has fractured it, so they kind of can't be. And you have people who just are siloed in their thinking, so they're never connecting the blood pressure to the blood sugar. It's just not something that they're thinking about. I do think with the advent of some of the medications on the market, actually, that more and more doctors are realizing, oh, with the blood sugar reduction, you actually get incredible kidney benefit and you actually see cardiac reduction. And that's, for better or for worse, that's the way a lot of doctors learn and think. It's actually through new therapeutic modalities, medications. And I think we're starting to, in traditional healthcare, starting to see it, but it's just so ignored, the link. And so it's all very much related. And if you can bring that hormonal response down, lower inflammation, you will see an overall cardiovascular improvement. One of the tests that we are adding on in our next kit too, we'll be looking at HSCRP, which is a measure of overall inflammation and cardiac inflammation, which is very important. And you'll find these, particularly, they look like fit individuals. Put them on a BMI chart. They're not even yet into class 1 obesity, and their inflammatory markers will be through the roof. And it's something that we should also be looking for early, because it's just a sign the body is not processing its fuel correctly. Whatever you're feeding it, however you're moving your body, if you're not doing it enough, you're not doing it the right way. And that's where the prevention should be happening.
So, I spoke to you, when we spoke earlier, before this podcast, I'm sure we were talking about the fact that this, to order an insulin, you still need a doctor to order an insulin.
Yeah.
Okay, so that now, if you're doing it online and you're going to send it to me and I'm in California, how does that work?
So with our testing kits, we work with a physician oversight group. And so there's someone ordering your labs who's licensed in your state and actually reviewing them. So they're real doctors behind the scenes reviewing the labs. And this is incredibly helpful for the consumer who just wants to test it, but then also for the practitioner who, because of state laws, can't order it out of their state or can't order labs at all. They can recommend clients who they're working with out of state to use our lab kits. And it's kind of a win-win situation. So the way our kits work is you order it online or referred online, and it's shipped to you, but behind the scenes, all of these things are happening with the doctors, and you just take a little finger prick test at home, pop it in the mail, and it goes to our lab, and then our doctors review it, and then it comes into your online portal. We've tried to make it as seamless and easy as possible. Because knowing your data shouldn't be scary, and it shouldn't be it shouldn't be complicated. But it's something that we have made very complicated. And a lot of doctors who even order lab tests, their hands are tied because you have to be licensed in the states that you practice in to order lab tests. And that's a story for another day. I think we should do away with that system, but it exists.
Especially in this day and age when there's so much now teleconferencing and telemedicine, where people may be consulting with a physician who's not in their state, and they want to be able to.
And they should be able to, because there's so few people who are practicing the way that we all think that they should be practicing, and it limits who you can see. If someone is practicing in a way that you want to embrace, you can't see them. So it's a tough thing. So we're trying to break down some of those barriers. In regards to the kits, one of the things that I've been telling you guys about offline was that we are releasing a second kit focused on the disease of PCOS, or polycystic ovary syndrome. And I know this syndrome very well, but polycystic ovary syndrome affects up to 20% of women, and they struggle the absolute most to get a diagnosis. And when they do, no one tells them that it is a disease of insulin resistance. So it is like the hallmark disease of insulin resistance. I think everyone can kind of think about it in terms of type 2 diabetes, but there is something about this syndrome where many of the symptoms that are related have an underlying insulin resistance element, and it can be very curative of all of the symptoms that come with it if you embrace a therapeutic low-carb lifestyle. But it's just not taught to OBGYNs and people doing the diagnosis. And unfortunately, because of that, 50% of women with PCOS will go on to develop type 2 diabetes by the time they're 40, which is just a travesty. And so we're trying to reach the consumer early, who I identifies, who's done some reading, who thinks they might have it, has had a hard time getting someone to listen to them. And so we're trying to help them get the diagnosis, but more importantly, get to the underlying metabolic element so that they can see it and they can understand. And they might be then more willing to embrace a lower carb lifestyle and say, okay, I don't need to take this just as my trajectory. Let's try to adopt a new lifestyle to make myself feel better.
Yeah, I think in that discussion that you're referring to that we had offline, there's a number of doctors that have reported to me that they've had this spike in pregnancies in their patient population, because they're treating obesity, type 2 diabetes, and a myriad of other conditions potentially. And they put them on a ketogenic diet, and not realizing that one of the other things that they suffer with that they haven't spoken to this doctor about is that they have PCOS. Often, like, as you say, it's undiagnosed, so they don't even know. And so now suddenly that PCS goes away, and they get pregnant. When they
I have to warn all my patients who don't want to get pregnant that you better be using some element of birth control, because you will now. It's so interesting. I've found that some of the doctors who are most embracing of a ketogenic diet are actually fertility specialists, because they have seen that in the course of the last 20 years in practice, and they're not scared of it in a way that I think most OBGYNs or just general doctors would be like, oh no, you can't be in ketosis to get pregnant, or you can't be in ketosis in pregnancy. They actually embrace it. And I will get a lot of referrals of patients ahead of pregnancy to kind of optimize, help people. And it's ahead of both fertility treatments and just trying to get pregnant. And it does work, because it makes ovulation more regular. It's amazing. And it's the way we were for years and years, right? Like, what were we eating for all the years that people got pregnant and kept going through the population? It's a ketogenic diet. So
I'd love to go back and look at evolution, because I think people forget that we haven't been eating the way we have, with a convenience store and a grocery store on every corner and a fast food place and all these recommendations to eat 3 meals a day and 2 snacks. And we didn't have that much food in our available realm. I mean, we had to hunt for it at times. We had to grow it and wait for it to ripen, and we didn't eat certain foods if they were out of season because it wasn't there. We didn't have strawberries in winter, and we just didn't eat constantly the way we do now. And I really love to look back at evolution and see we evolved as a human population, as a species, by having times where we didn't have food and still being able to procreate and have babies and make and more generations. So I love that you point that out, just to make sure that people start thinking along those lines.
Right. We need to look back before 20 years ago, and 40 even. It was different. And we need to go back more to basics and teach our kids too. It's hard. It's very hard. I have little boys, and we just had a play date yesterday at the playground in the mid-afternoon, and one of the moms, who was lovely, brought all of these snacks, right? And then we have discussions at home about how we don't snack, and there are very special things for treats, but you can't have them all the time. And it's a hard world that we ask kids to try to kind of adapt to. And we like sweet things, right? Like, we like hyperpalatable things, right? So do dogs. You put excess food in front of a dog, they'll eat it. They want sweet treats too. And it's hard to say no to them. And we need to do a better job really kind of teaching the next generation.
Yeah, that's brilliant. Thank you so much for taking the time to tell us about this, and look forward to working with you. You guys are going to have a presence at our next event to teach physicians and that about this kit that they can make available to their patients and stuff. So that's going to be brilliant.
We're really looking forward to it, and anyone can reach out to me at any time. I'm happy to hop on a Zoom and explain our kits, and we're trying to put together what we'd really love to do is just more education around it, right? So people can understand what to do with the results.
Right.
And so
and
we
so
really look forward to that.
That reminds me. how do people find you? How do they get
Yes.
hold of you?
Yes.
What's your website and your
Yes.
social media
So find
handles?
us. Yes. So find us on the web at getsowell.com, and we're on Instagram at the same handle. We are about to undergo a new site relaunch, and we're about to launch our second kit, the PCOS biology kit. Right now you can find our weight biology kit, and we're going to be rolling out some new kits where you can just test your insulin monthly. And we're really listening to what you all want. So tell us what you want, and we're creating it. But find us at getsowell.com, and happy to answer any questions. I love connecting with practitioners in the community, and love serving those individuals in the community who are just looking for their own solutions.
That's fantastic. Awesome. And we can't express enough that it's just a finger prick. You don't actually have to make a trip to the lab to do it. You might do the fasting involved. You have to be fasted.
So we have you fast, and we have you do it in the morning, but that's the most complicated part about it.
So it makes it so much easier.
Yeah, it's just a finger prick, and it's really, I made sure that it was an easy process, and we really walk people through it. And for anyone wondering, the lab that runs our labs it's called CLIA certified. They are an amazing facility, and we've tested against venipuncture, or the venous blood draw. And we have great specificity and sensitivity to our tests. So it's a valid test, and I'm thrilled to offer it.
That's brilliant.
That's so wonderful. And you are available for patient care, or are you still accepting patients by any chance? Or?
Yes. You can reach out to my private practice, and you can find me at alexandrasowamd.com. And I'm at the same handle on Instagram too, Alexandra Sowa MD. Yes, we have some limited availability for patients. We're really trying to scale what we're offering through Get So Well. But yes, I do still see patients.
Excellent.
Because honestly, I can't give it up.
I know you're just, when you're so passionate about helping people, you've just got to make the space for it. Alexandra can be found now on the listing on the Society of Metabolic Health Practitioners. And if you find for some reason that she's not able to accept you, there are other people that you could look for to find in your area to support metabolic health needs. Okay.
Wow, this is so much fun, guys. Thank you so much.
No problem.
Absolutely. Thank you. Thank everybody for joining us and listening in.
You've been listening to an episode of the LowCarbUSA podcast. You can support us on Patreon at patreon.com/LowCarbUSA.